Okay, so good evening, everyone, and welcome to today's Asset Colloquium, which is going to be given by Dr. Carlo Caduff from King's College London, who is actually incidentally is in Mumbai at this time, and he's going to talk on Specter of Comparison, thinking beyond numbers. Of course, this is no prizes for guessing the background. This is in the context of COVID-19 pandemic. Just to say of words about today's speaker, but before I go further, I would like to sincerely thank Sandhya for proposing this talk and make this happen. Thank you very much, Kausika. Um, Carlo Caduff is an associate professor in global health and social medicine at King's College London and director of postgraduate research studies and chair of the culture, medicine, and power research group. As a social scientist, his research examines the social, cultural, political, technological, and economic dimensions of cancer care in India. And he particularly works with the National Cancer Grid and TMC. In fact, he has been with TMC for over 5 years now and working mainly to decentralize the cancer treatment in India. And you know how difficult it is for all the cancer patients from the country, just coming all of them to TMC in Mumbai. So in the context of that, I think this work has to be, is really great. He's the principal investigator of the Grid Oncology Wellcome Trust project, a 5-year collaborative research program in the changing landscape of cancer care in India. That's exactly what I was telling about. Earlier, he worked on a project on pandemic preparedness in the United States and published the pandemic perhaps, which is actually published in the University of California Press in 2015. And Dr. Caduff is an affiliate of King's India Institute and visiting faculty at the Graduate Institute, Geneva. With colleagues at King's, Harvard, and Johns Hopkins, he launched the Global Social Medicine Network to link, support, and build upon existing interdisciplinary social medicine programs across the world. Carlo received his PhD in anthropology from the University of California at Berkeley. So with these two words, I request Carlo to start his colloquium.
Thank you so much for the kind introduction and the invitation to speak in the colloquium. It's a great honor to be here and to share some of my insights on the COVID-19 pandemic. So let me just try to share the screen for the presentation. All right. So for today, I thought it might be interesting to talk a bit about numbers because numbers have been so essential in the context of the COVID-19 pandemic. The talk has the following structure. So the first section will be dealing with the question of preparedness. What is preparedness? Then I'll be talking a bit about statistics. Then we'll look at two different case studies, which are interesting for a number of reasons. We'll have a look at Switzerland, what has happened in Switzerland in terms of the COVID-19 pandemic and lockdown. Then we'll shift to Turkey. And then I have a few final thoughts about thinking about COVID-19 beyond numbers and beyond comparison. So my background, I was trained as a medical anthropologist at UC Berkeley, so I'm a social scientist. I teach in the Department of Global Health and Social Medicine at King's College London. And I've been doing a study on pandemic preparedness in 2005 to 2015, and I've been focusing on the United States. Back then in 2005, there was a lot of concern around the avian influenza virus that was spreading among birds. And many scientists and experts were concerned that this virus might adapt to humans and then cause a catastrophic pandemic. Now that catastrophic pandemic never happened. The virus didn't quite adapt to humans. But instead we got something completely else, namely COVID-19, which is a very different virus. Then in 2015, I shifted. I started working on cancer care in India and having been working on this topic for a number of years, working with the National Cancer Grid, trying to understand how cancer care can be decentralized, how it can be standardized, and how it can be digitalized for the benefit of patients. So let's start with preparedness. Preparedness is a new term that came into use, especially in the United States after the terrorist attacks of 2001. At that time, a lot of experts, politicians, policymakers began to think about how to prepare health systems, how to prepare a country for a catastrophic event, either a terrorist attack or a catastrophic pandemic. Remember, in 2001, there was not just the terrorist attacks. There was also the anthrax attacks, which caused a lot of fear and panic in the United States. So there was a lot of concern around questions of bioterrorism as well. And so then preparedness became a key term that was used by many experts and politicians and policymakers. And a lot of resources have gone into preparing the United States for a catastrophe. So I have here the National Strategy for Pandemic Influenza. This was published in 2005 by the Homeland Security Council, also in response to the avian influenza virus that was spreading on birds. So many government institutions came up with plans for the US to prepare and be ready for a catastrophic event. There was also a plan that was published by the WHO, the World Health Organization. They published a global influenza preparedness plan and came up with recommendations and suggestions for how countries could prepare for a pandemic, for a catastrophic pandemic. So as you can see, over the last 20 years, a lot of thinking went into how to prepare for a catastrophic pandemic, what to do when a new virus emerges and starts to spread in the population. So a lot of plans were published, a lot of guidelines, a lot of exercises and drills were done, a lot of trainings happened, a lot of resources went into the idea of preparedness, and a lot of work was done around it. So when COVID-19 happened, you can't say that countries were not prepared. Actually, they had been preparing for something like this for a very long time. And the United States especially invested billions of dollars into preparedness. Now, for some reason I can't move on. Oh, now it's moving on. But now part of this investment in preparedness was also dedicated to trying to measure preparedness. And I want to discuss quickly here one report that was published in 2019. It's the Global Health Security Index. And it was a report that was trying to assess preparedness across the world. It was done by a group of experts based at Johns Hopkins University, and it was funded by Bill and Melinda Gates Foundation and others. So there was a project team who included 21 experts from 13 countries. They developed a framework with over 140 questions. They had 34 indicators and 85 sub-indicators to assess a country's capability to prevent and mitigate catastrophic pandemics. And they looked at a whole number of different things. So they looked at questions around prevention, how to prevent an event from happening. They looked at the detection and reporting. They looked at rapid response. They looked at the health system as such. They looked at compliance with international norms. And they also looked at the risk environment. So they came up with a scoring, a ranking of all the countries in the world were ranked according to their level of preparedness. And according to these experts, the United States was the most prepared country in the world for a catastrophic pandemic. On the second rank, you can see they put the United Kingdom. So the UK and the US were seen by these experts as the most prepared countries in the world. You can see other countries like France is also very high, Switzerland, Germany, Spain. And India was also pretty high. India was ranked as number 57 globally as a relatively well-prepared country for catastrophic events. Now, of course, in the context of COVID-19, this sounds strange because when you look at what's happening in the United States and when you look at what's happening in the UK, you wouldn't probably say that these countries have a good response to the COVID-19 pandemic. On the contrary, it seems that these countries are dealing with huge challenges, and that, in fact, other countries have been dealing much better with the COVID-19 pandemic. So when we put the ranking next to the COVID-19 numbers, there's a slight cognitive dissonance, and it raises a number of questions. First of all, is this a failure of expertise? Was this report simply fantasy? They did not really reflect reality when they decided to put the United States and the UK at the top of the preparedness countries, or the most prepared countries. So was it a failure of this expertise? Is it a question of pretension versus reality, that these countries just pretended to be prepared, but in fact it was all just about plans, but plans are not really making countries prepared? Or has the investment in preparedness itself made the US more vulnerable? So it could also be that maybe preparedness itself is not the solution, it's actually a problem, and that therefore we need to think more carefully and also more critically about preparedness as such. So in order to explore this question in more detail, we need to first understand what is preparedness in the US in the first place. So over the next few slides, I'll be discussing in more detail what shape preparedness took in the United States over the past 20 years, so that we can get a better sense of what this term actually means. So the fragility of the public health infrastructure in the US has always been a reason for investing in preparedness as well as a result of preparedness. So this is my first claim. So here is an example. State governments in the US closed down hospitals to rationalize medical care, reduce so-called oversupply, and make it more efficient. But then the remaining hospitals were asked to prepare for a pandemic and come up with emergency plans. So this was one form that preparedness took. Hospitals were on the one hand closed because there was a sense that there are too many hospitals, they're too expensive, and there are too many empty beds. But then at the same time, the remaining hospitals were asked to prepare for a pandemic. What happens when suddenly we need more beds? So this contradiction has been at the heart of preparedness in the United States, where on the one hand, excess capacity was replaced with surge capacity, and that has not worked so well in the current pandemic. So preparedness in the US always assumed that the public health infrastructure would not be able to deal with a pandemic, that it would be overwhelmed very quickly. Hence, the emphasis was on coming up with plans to minimize the disaster, not to prevent it. The focus was always on plans, on guidelines, on drills, and exercises. It was less on building infrastructure, it was less on building hospitals, it was less on stockpiling, it was less on investing in people, and instead the focus was on these things. This is a graph which shows you just hospital beds per 1,000 people, comparing South Korea, China, Italy, and US, and you can see the US has 2.8 beds per 1,000 people, while South Korea has 12.3. So as you can imagine, in a pandemic where you suddenly need more beds than during normal times, South Korea is in a much better place than Italy or the US. But this is just one indicator that shows you what might be the problem. Now, the other thing that we saw is that, for instance, in April 2020, in the midst of the pandemic, American hospitals cut salaries, laid off hundreds of staff, and sent others on unpaid leave because the pandemic response cut off a main source of income, with patients avoiding hospitals due to fear of infection. Hospitals and nursing homes in the US laid off over 260 staff in one single month. This is quite surprising. So in the midst of the pandemic, hospitals and nursing homes laid off 260,000 people, staff, simply because of financial reasons, because the pandemic cut off a huge stream of income. And the only way of responding to this financial crisis was by laying off staff. And of course, that made the system even weaker because of the growing financial pressures, because patients were avoiding the hospital, because the hospitals were not able to conduct elective surgeries and so on, and because they were asked to focus entirely on the COVID-19 response. So this raises the question, how prepared is the US actually for a pandemic? Now, the other thing which is important to understand in terms of the US is that after the terrorist attacks on September 11, 2001, the US government spent billions of dollars on preparedness. But a lot of the resources went into biodefense projects in order to prepare for anthrax and smallpox attacks. So the key scenario was not something like COVID-19, but it was anthrax and smallpox, which were seen as potential bioterrorist agents. So there was a massive increase in high security biodefense labs. In the 1990s, there were 5 BSL-4 labs, which are high security labs. But then in 2017, a government report counted 270 high containment select agent labs in the United States. And the actual number is almost certainly higher because some of these labs are secret. So you can see there was a huge expansion of high security biosafety labs since after 9/11. But at the same time, it took the United States so many months to set up a decent systematic testing and tracing system for COVID-19. Again, here you can see some of the contradictions of preparedness in the United States. Now, the last aspect of preparedness in the United States, which is important to understand, is that a lot of emphasis was put on citizens, and citizens were seen as being responsible for their own survival. There was a National Preparedness Month, and citizens were asked to come up with their own plan, to think about what they would do in the case of an emergency. And the suggestion was that the state could only do so much, but most of the preparedness should be done by citizens themselves. So this is an important other aspect of preparedness in the US. Now, this raises, of course, the question of what kind of preparedness do we want? Is this the kind of preparedness that we want? Is this a preparedness that is efficient? Or do we actually need a different kind of preparedness? So I'll shift now to the second topic that I wanted to discuss, which has to do with statistics. And I wanted to go back to the original meaning of the word. Some of you may know that the German statistic was first introduced by a scholar named Gottfried Achenball in the 18th century, and it originally designated the collection and analysis of data about the state. So the word statistics contains the word state, and that is not a coincidence because statistics merged as the science of the state. and it was also called, in the 18th century, political arithmetic. So what we understand by statistics today is something slightly different from what it meant when the term was coined. It only acquired the meaning of collection and classification of data more generally in the early 19th century. I have here a quote from a scholar from 1787 who pointed out that it is about 40 years ago that branch of political knowledge, which has for its object the actual and relative power of the several modern states, the power arising from their natural advantages, and the wisdom of their governments, has been formed chiefly by German writers into a separate science. This science, distinguished by the new coined name of statistics, is become a favorite study in Germany. So again, you can see here that statistics meant the science of the state and comparison between the actual and relative power of modern states with each other. There's a second quote here: the science that is called statistics teaches us what is the political arrangement of all the modern states of the known world. So the word statistics and the science emerged in a context where European states were competing with each other, nations matching themselves against each other in a struggle for power. So this is how the science of the state statistics took shape. Now, the specter of comparison today looks, in the context of COVID-19, looks something like this. So you can see here the numbers of Italy, Switzerland, and Turkey. Again, we're comparing states with each other. Again, we're looking at numbers, statistics. We see case numbers. So Italy has 1 million cases up until now, and 43,000 deaths, while Switzerland has around 250,000 cases. So that's about 1/4. But it has only 3,000 deaths so far. And then Turkey is another interesting case, has up until now 404,000 cases, but only 11,000 deaths. So as you can see, the proportions are quite different. So it seems that Italy has not only more cases, but also that the proportion of the people who died is much higher compared to countries like Switzerland and Turkey. So this raises a number of questions. And in order to discuss these different numbers and what they might mean, I want to look at Switzerland and Turkey in a bit more detail, and then talk about numbers in general. And you will see why it was important to keep in mind that statistics emerged as a science of the state. So let's look at Switzerland. Switzerland is a high-income country. It has 8.6 million population, and the population density is relatively high because a lot of the country is mountains. Then it has also a considerable migrant population. Now, this is the total numbers, July versus November. So as you can see, in July, Switzerland had 33,000 cases and about 2,000 deaths. It now has 250,000 cases. So you can see there was a huge jump in terms of the cases, but only 1/3 more deaths. So cases have increased massively, but deaths have not increased yet so much. So that's important to keep in mind in terms of what has happened during this pandemic. Now you can see here how the pandemic took shape in Switzerland. This is quite common across Europe. It's very different from places like India. So there was one peak which was in March, but even compared to March, what we're seeing today is on a completely different level. So cases have exploded quite a bit. And as you can also see, over the summer, there were hardly any cases, even though there was no lockdown over the summer. So that's quite strange. But this is the dynamic and the structure that the pandemic took. in many European countries with a very similar structure. Now let's look at the Swiss lockdown, which took also a particular shape. So it was a kind of a light touch lockdown. It was not comparable to other kinds of lockdowns like in France, Italy, or India. So at the end of February, large events were banned. Then in March, the border to Italy was closed and the schools were closed. And then on 16 March, non-essential shops, restaurants, and bars were closed. There was no closure of offices. Work from home was encouraged, but not mandated. There was no ban on transportation or restriction of movement. People were only encouraged to stay at home, but they could move if they wanted to move. There were no face masks required in public, and there was no curfew type of intervention. So as you can see, the lockdown was a light touch lockdown. Then a month later, on 29th of April, the shops were allowed to open again, restaurants as well. Then on 1st July, face masks were required for public transportation. And then more recently, new restrictions were introduced in late October, which are similar to the first lockdown, although they are even less restrictive. So shops and restaurants are still open, but they have to close at 11 p.m. So this is the Swiss lockdown. Now, I want to spend a bit time looking at this graph because it's quite important and it illuminates something quite interesting. This is the weekly number of deaths in 2020. And you can see here two curves. One looks at age group 65 years and older, and one looks at age group 0 to 64 years. Now, this is important in the context of COVID-19 because we know that people who are older than 65 are at high risk of death, while people who are younger than 65 have a much lower risk of death from COVID-19. So it's important to look at these different populations separately. So as you can see, this is just counting the numbers of deaths. And you can see here the green stream shows you the average number of deaths that would be expected at that particular time. So this is what you would expect here in terms of death for this particular age group. And as you can see here, when you look at the age group of 0 to 64, the actual number of deaths in 2020 remains within what would be expected on average. So you can hardly see a COVID-19 pandemic within this age group. Now, it's very different for the age group 65. There's a clear peak here, which is obviously the COVID-19 pandemic. This is excess deaths that happened precisely because of COVID-19. But it's important to also keep in mind that the numbers of deaths before the COVID-19 pandemic happened was quite low. It was very, very low. And then it went up very quickly, and then it came down to a very low level again. And so this is important because when you look at the mortality again in the age group 65 and older in Switzerland, and you just count how many people died, and I did this for up until week 27, which was July, you get 31,278 for 2020. So this includes the COVID-19 pandemic. But when you compare this with 2019, again, the same weeks, you see that the difference is not much, right? So here we have 31,270, and 2019 up to week 27, we had 31,205. So that's quite interesting, and I'll explain this in more detail just in a minute. Now let's look at what happened after March. So again, as you can see, the numbers came down on a very low level, and now you can see again there's an increase in excess deaths that has happened just now in November. But again, in the age group 0 to 64, there's hardly anything happening. And I did again the same thing. I just counted all the number of deaths in 2020, now up until week 44. And what you get is 49,900. Now, when you compare this with 2019, last year, again, same weeks, you get 49,074. So you can see the difference is not much, right? It's not 3,000 deaths. It's actually approximately 900 deaths more. Now that raises some questions, and one way of explaining this is through the concept of mortality displacement. So what is mortality displacement? Mortality displacement is a term that is used by epidemiologists in the context of heat-related mortality. So in the context of heat waves, mortality displacement was observed in Europe during heat waves. And what does it mean? So what it means is mortality displacement is a phenomenon where the heat principally affects individuals whose health is already compromised and who would have died shortly anyway, regardless of the weather, right? So estimates of mortality displacement are often calculated for defined heat wave periods that include before, during, and after the heat wave period, lasting typically less than 2 months. So this could well have happened in the context of COVID-19, where because people who are older than 65 and have some comorbidities and are at high risk of dying and have a very low life expectancy, they may have died a few months before they would have died anyway because of the health conditions. And so what might have happened is mortality displacement. And so that means that the mortality over a number of months is actually not much different from prior years, precisely because this phenomenon of mortality displacement might have happened, at least to some degree. So there's a puzzle here. On the one hand, we have a light touch lockdown. There is perhaps a significant mortality displacement because when you look at the total numbers and compare them with prior years, there's not a huge difference. And so there's a relatively low number of COVID-19 deaths. And so that raises the question, is Switzerland a success story? Maybe it is, maybe it isn't. There are some contingencies that we need to take into account. Maybe it was just sheer luck that other countries had a much worse pandemic than Switzerland. Maybe it's due to the demographic and the socio-economic structure. Maybe it is due to the quality of the healthcare system, that the healthcare system in Switzerland is better than the one in Italy or France. Maybe it has to do with the fact that there was an efficient test, trace, and isolate protocol. Maybe it has to do with the fact that there were no large outbreaks in nursing homes. But it might also be that we will see more cases to come over the next few months and years. And so the picture might change quite a bit, perhaps, or perhaps not. So let's look at Turkey quickly. Turkey, again, is interesting because the number of deaths is also quite low compared with other countries. So despite the wide circulation of the virus among the population and rapidly increasing infection rates, what is striking is Turkey's relatively low mortality rate. So these numbers are from July, 5,000 deaths in a population of over 86 million people. So what was Turkey's lockdown? Again, it was very specific. It was different from the lockdowns in other countries. First of all, there was a restriction of movement for those younger than 20, unless employed, and those older than 65. So restrictions were only affecting these populations. Large events were suspended and schools were closed. So again, you can see that the principles used for the lockdown were very different from other countries. The strategy was a targeted lockdown to protect those at risk and keep the workforce mostly at work. So here the key focus and the key concern was the economy. Now, What I would like to highlight in the context of Turkey is that the highly polarized climate of the country created two camps around the official figures. The pro-government camp suggested that Turkey is doing great in its crisis management, while the opposition, on the other hand, focused on the rising infection rates and the unreliability of the mortality rate. So the numbers became extremely political. This is a quote from an article that is quite interesting regarding the COVID-19 pandemic in Turkey. So they concluded that the crisis provided the ideal context for the government to show its commitment to deliver, and for the opposition to make its case for the government's incapacity to deliver. The statistical figures ended up as the key references to objectively measure success or failure. So this brings us back to what I was saying before about statistics as political arithmetic, as signs of the state. So what we see today in this concern with numbers and in the way in which numbers are being used, we see a return to the original meaning of the word statistics as signs of the state. So different states are being compared with each other on the basis of COVID-19 numbers. At stake is knowledge of one's own and other states' respective forces and capacities to deal with the COVID-19 pandemic. And the enhancement of the state's strength occurs within a competitive framework where different states are being compared with each other. France is being compared with Italy, Italy is being compared with Switzerland, Switzerland is being compared with Turkey, Turkey is being compared with UK, and so on. So what we witness today are political contestations, both within countries, but also between countries, using numbers to determine a state's success or failure to contain the spread of the virus. But now there's a problem with such comparison. And I just want to highlight the problem in relationship to one key question. And that key question is, what is a death caused by COVID-19 in the first place? So we'll begin to see some of the problems with these kinds of comparisons. This is the case of Belgium. In Belgium, COVID-19 deaths were counted independent of any testing. So of 52% of all deaths, only 4.5% turned out to be confirmed by laboratory test as COVID-19 positive. Almost half of all deaths were merely suspected to be linked with the virus, but had never actually been tested. So obviously this is quite problematic in terms of the quality of numbers that we get from a country like Belgium. Now let's look at Italy. In Italy, COVID-19 related deaths are defined as those occurring in test positive patients independently from pre-existing diseases that may have caused death. However, test positive patients who die because of a heart disease or terminal cancer are not necessarily dying because of SARS-CoV-2 infection, yet they appear in the statistics precisely because this is how the numbers were collected in Italy. Now in England, we have a similar problem where NHS, National Health System data, on confirmed COVID-19 positive cases is linked with the NHS death register to identify COVID-19 deaths. So patients who have tested positive but successfully treated and discharged from hospital will still be counted as COVID-19 deaths, even if they had a heart attack or were run over by a bus 3 months later. So again, you can see that this is a very problematic way of counting COVID-19 deaths. So what we have today is a semblance of comparability. There is no actual comparability. We just pretend that we can compare countries with each other. But different countries have different ways of defining COVID-19 deaths in the first place. So what counts as a COVID-19 death in the UK is not the same as in Italy, and it's not the same as in Belgium, and it's not the same as in Switzerland. There's often a confusion between patients who die with the virus and those who die from it. So obviously that's something different. Someone who dies with the virus is not necessarily dying from it. He or she may die from something else. Given the incoherent way in which COVID-19 deaths are counted, comparison between countries is impossible. So lists of COVID-19 deaths and rankings of countries create a semblance of comparability. This is a quote from philosopher and historian Sabina Leonelli, who has written about COVID-19 statistics, and she concluded that robust data interpretation would involve comparing the different conditions under which data are produced and collected, including the different testing strategies adopted by each country and sometimes each region and municipality, and the ways in which deaths and infections are counted. So only then could we begin to compare countries with each other. So this raises the question of why this pandemic of comparison? Why this constant ranking of countries? Well, the practice of comparing states with each other on the basis of numbers reflects the original meaning of statistics, science of the state, measuring the power of individual states and comparing them with each other. So that's one thing that is happening today. And this reflects what Benedict Anderson has meant by the specter of comparison. That the phrase is from his book. He concluded that the specter of comparison arises as nations stir into self-awareness, matching themselves against others and becoming through the exercise of the imagination. So in the context of nationalism, countries begin to compare each other, and that's how comparison has been working also as well in the context of the COVID-19 pandemic. This is another example now taken from India. This is from the Indian Express, the headline, 1 million COVID-19 cases in India, but fewer deaths than US and Brazil. So again, you can see here how different countries are being compared with each other. It is presumed that one can compare these numbers, how it is obscured that actually these countries may count deaths in very different ways. But again, it's an attempt to say who is doing well and who is not doing so well, etc. So the specter of comparison is part of a nationalist mindset. It's an effort to compare nations with each other in global power competitions. Which country is doing well, which country is not doing well. There's a lot of focus on Australia and New Zealand. So this is what's going on today. But it's also part of internal political contestations in often polarized party systems. Now, a good example for this is the US and the UK, as well as Turkey. So where there are internal political contestations. But it's also part of a moral discourse, assigning praise and blame, which country is doing well, which country is not doing well, what is a success story and what is not a success story. And it's also part of an audit culture, an attempt to measure performance and effectiveness through seemingly objective numbers. So an example of what I was talking before when I was talking about the preparedness report that was trying to rank different countries according to their level of preparedness. So that's another example of audit culture. And finally, it's part of a globalization process, an attempt to standardize things to make them globally comparable. But as I was saying before, the comparability is only a semblance. Very often there is no comparability whatsoever. So how can we think beyond rankings and comparisons? How can we go beyond this mindset? How can we go beyond this obsession with numbers? And I want to conclude with a couple of key claims, which I have taken from a scientist whose name is François Balloux, is working at he's working in London, at University College. And he has written a few very interesting things. So I'll just conclude with some of his key claims. So he suggested that the debate about how to respond to the COVID-19 pandemic is often framed as a scientific or a scientific economic problem. But I do not believe it really is. Instead, it is primarily a moral and ethical conundrum. The main reason is that there is no solution, only trade-offs. And this is his second claim. Any rational, scientifically driven strategy would require addressing some uncomfortable, possibly unanswerable questions, such as, what is the relative value of a child's education, of the life of an elderly person in a care home? Many countries do not seem to have a clear long-term strategy. For those that do, for instance, Sweden or Singapore, I believe their motivations and policies are generally equally moral and ethical. The difference is the weight they put on mutually exclusive objectives. He also suggested that between country comparisons of COVID-19 mitigation strategies may not even be particularly informative with the benefit of hindsight. Countries are interdependent and every single epidemic is unique, with local and stochastic factors playing an important role. So this is another reason why these comparisons are very problematic. Finally, he pointed out that each country faces a unique, idiosyncratic challenge and has to respond with the means at their disposal. As such, it may often be pointless to compare the performance of their COVID-19 strategy at this point, at this stage of the pandemic, right? So one example would be New Zealand. New Zealand is a very small country, it's an island. So it's much easier to control a pandemic than a big country like India, which is not an island. Finally, he said that there's no solution and those who claim otherwise are insufficiently informed. As such, it would be helpful if we could get over the endless sloganeering and engage in an adult and honest discussion about what we value most and reach responsible decisions accordingly. So let me conclude with a couple of questions. One question is, are interventions that we are seeing today in many countries, especially in Europe, where new lockdowns are being imposed, are interventions mainly driven by seemingly objective numbers and the specter of comparison? Has the obsession with numbers, comparisons, and rankings sidelined a concern for democratic norms and values? Have governments shown a commitment to empower communities and build institutions for social welfare? Again, I have here a headline from an Indian newspaper. COVID-19 latest, India's top 15 states with highest recovery rate and numbers. Again, you see here that everything is being evaluated in terms of numbers, but this focus on one single value, namely numbers, cases, might obscure that there are also other values that might be at stake. So we could produce other rankings, which would put other values or registers of value at the top. And I have here a number of them. So for instance, we could ask the question, which countries have enabled fair and equal access to healthcare? So we could rank the entire world and the response to the COVID-19 pandemic using this principle or this value, and we would get a very different ranking, right? We could also focus on which countries have attended to socioeconomic inequalities. So which countries have done well in terms of this particular value. Or we could look at which countries have facilitated community response. We could look at which countries have enabled and respected opposition and disagreement, and we would get a different ranking again. We could look at countries which have cultivated openness and experimentation. We could make this our key value and then compare countries on the basis of this principle. Or we could look at countries which have taken the pandemic as an opportunity to strengthen democracy. Or we could look at countries which have used the pandemic to start building a sustainable future. Again, if we shift our perspective, if we shift our values, if we look at more than just numbers and bringing numbers down and flattening the curve, and expand our horizon of what might be important in terms of our response to the COVID-19 pandemic, we might get very different rankings and very different conversations as well. And so that raises, of course, again, the question, what does success mean? On the basis of what do we decide as a country implemented a successful strategy? Again, this is just an attempt to open the horizon, to include more values, and to think beyond the numerical and statistics, because other things matter too. So with this, I want to conclude the presentation. And I would like to thank you for the attention. I hope this has been interesting and inspiring. Let me just stop sharing the screen. All right, excellent.
Yeah. Thanks, Carlo, for a very different perspective on COVID-19 and, of course, in general, the pandemic, which has been your main field of work. And much beyond the numbers and the rankings and so on, I think you have put a perspective as a social scientist, a more deeper and a more on how things should be evaluated. Of course, it's very interesting perspective. And with those couple of comments, I now keep your lecture open and request questions and comments from both the Zoom and the YouTube participants. And the participants on Zoom, of course, they can just open their mic and they can talk. They can ask questions, or you can even flag yourself. By the time maybe questions open up on Zoom, let me take a couple of them from YouTube.
Sure.
Okay, actually, this is more of a comment from Arnab Bhattacharya. Thought-provoking but hard-hitting and important questions. Fantastic talk. Also another, okay, it's a comment again. Gupta, thanks for the excellent talk and helping us expand beyond the technocratic discourse on COVID-19. And one question from Abhinav Chaudhary, it says, what is the reason behind the low death rates in certain countries? And is this data a little bit misleading?
That's a great question. I mean, as always with these numbers, the question is, how reliable are they? How robust are they? I think for each country, we would have to look into detail and explore the way in which the numbers have been collected, how COVID-19 deaths have been defined in the first place, and only then could we get a sense of the reliability and accuracy of these numbers. So that's why I found it much more interesting and important to look at excess deaths, because that's slightly more reliable. The numbers that I showed you from Switzerland are from the Swiss government, and they're just counting how many people died per week. And that's quite a reliable number, because it's not depending on diagnosis. It's not depending on deciding whether this particular person died with the virus or from the virus. So in that sense, these numbers are much more interesting in my view. There was a very interesting paper that was published, and I can try to find it and show you the graph, which compared excess mortality across different countries. And it was quite interesting to see that some countries had huge excess deaths happening during the first wave in Europe, and other countries, they had hardly any excess deaths. And Switzerland was somewhere in the middle. But as I was explaining to you, even when you look over several months, these excess deaths disappear because the mortality rate before the peak and after the peak was extremely low. So that's, I think, what I would, how I would approach the question. But it's a very important, but also very tricky question.
There's one question from Sandhya Kaushika. I'll read for her. How can one measure both the quality of healthcare system and equal access to it?
Yeah, that's I was just trying to find the piece. That's an excellent question too, and again a very complex one. Um, Healthcare systems are extremely complex, and they're very different. The UK has a national health system. The American system is a privatized system, so they work in very different ways. India has, on the one hand, private hospitals, private corporate hospitals, but then also government hospitals. And it's a huge country, so the attempt to measure quality of healthcare is important, but it's really difficult.
Are there any more questions from Zoom audience participants? Also from you?
Satya, can I
Yeah.
ask a question?
Yeah,
So
please.
you started your talk by talking about pandemic preparedness and how it sort of had failed. Does that mean that the people who put in place whatever pandemic preparedness or what Obama is to call his, rule book, you never addressed the question of whether that preparedness plan was flawed or was there a problem in implementation? And if so, you identified one that you just now had surge capacity, you did not have underlying large capacity. But are there, is that something one can't even aim for, which is preparedness for major public health disasters, for instance?
Again, this is an excellent question. I think the US is a very special case, and I think other countries have. I mean, when we look at excess deaths, I think it's difficult to say at this point, but I think what we're seeing that some countries have really done much better than other countries, and the US and the UK have done really bad, and it's not just explainable by the different demographics or the different ways in which the healthcare system is structured. Now, when it comes to the US, I would say the following thing. If this would not have been a COVID-19 pandemic, but it would have been a bioterrorist attack, I think the response would have been very different. Precisely because the threat itself has a very different meaning. If a bioterrorist attack would have happened, the US would have gone into preparedness mode within 5 seconds, for very political reasons, precisely because it has been preparing for a bioterrorist attack so much, and because it has always used these kinds of terrorist attacks for nation-building purposes. So I think Trump's reaction to a bioterrorist attack would have been very different. So that's one point. The other point has to do with the US is a very privatized, fragmented system. And so a privatized and fragmented system will always have huge issues, and will never be able to deal with a pandemic in the way in which another system that is organized in a different way will be able to deal with a pandemic. The third point has to do with what you already mentioned, that surge capacity cannot make up for a lack of access capacity. You can't just build hospitals within a couple of months. And the last point I would say is, when you have huge populations which already have a lack of access to healthcare, when you have poverty, when you have inequality, when you have huge structural issues, in addition to huge infrastructural issues, and I think it becomes very difficult to respond to an event such as this one. And then things get even more complicated when you have a government, an administration, which is completely incompetent, incoherent, and doesn't take the threat seriously. So I think there are a number of reasons which account for the failure of preparedness. Some of these reasons have to do with the structure of the United States. Some of them have to do with the problems with infrastructure. Some of them have to do with structural issues. Some of them have to do with the privatized, fragmented health system, and some of them have to do with the preparedness itself, because preparedness cannot prevent the event from happening. It can only mitigate the consequences or some of the consequences.
Thank you.
Uh, one more question from Professor Arna Bhattacharya. Um, the preparedness rankings were strange, especially US at the #1 position. Does it mean that in the past there was a proper playbook for dealing with a pandemic that was intentionally abandoned by the government, or was there no plan?
No, there were plans. I mean, this report is from 2019. It was published in October 2019, so it's very actual and contemporary. There were lots of plans available, but most of these plans were not put into practice. And so I think for future scholars, it will be important to understand why these plans were not put into practice by governments and public health officials did not make use of them. It could be simply, or one reason could be because the government didn't invest in proper surveillance. And so without surveillance on the ground, it becomes very difficult to, intervene. If you don't know what's going on in your community because you don't have enough testing capacity, it becomes very difficult to decide what to close and how to close and how to contain the outbreak because you just have no idea what's going on. So that was the case very, very early during the pandemic because local public health officials simply didn't know what was going on because there was no testing or not enough testing happening. So plans were there, but of course putting plans into practice, that is another challenge, and that might have been one other problem, that it's easy to come up with a nice plan, but then putting it into practice is a different thing. And finally, I think it's important that we had someone as president who didn't take the threat seriously and thought the virus would go away on its own. And I think that kind of incompetence has also hampered the response a lot. And then different states within the United States were doing different things because they're quite, autonomous to some extent from the national government.
I do not see any more questions, but I would like to take this opportunity that you are having here. The point that you are, this question is not about the topic of today, but the points that you mentioned just before the talk started, namely, this is your work that we are doing in India regarding, let us say, national cancer grid and TMC. And the question is, you are actually working to decentralize the cancer treatment in India, which is a big problem. I kind of mentioned briefly that patients from all over the country trying to kind of travel to TMC here and all the problems concerned. And you also mentioned that you are working on developing and standardizing methods and even using the digital technology in this area. If you could just share a couple of minutes on this work, I think that will also be interesting to hear from you.
Yeah, so this is a collaboration with Tata Memorial Hospital at the National Cancer Grid. So they invested a lot of work, for instance, in building new hospitals across the country and providing training to the doctors working and administrators working in these hospitals. They invested also a lot of work in coming up with new guidelines that are specific for the conditions that you encounter in India. So they try to come up with their own guidelines and not just copy paste those from high income countries, partly because the types of cancers that you see in India are different, partly because the resources are different. And so the conditions are very, very different. So it's important that countries have their own guidelines that take into account the realities on the ground. So they came up with a whole range of different guidelines for different tumor types. And then they also invested in new digital technologies to make access to expertise in cancer care easier for patients to access. So what we want to do with the project is we want to look at what is successful and where are the challenges, what is working well and what is not working well. And for that, you need to talk to patients, and you need to work with family members, and you need to work with hospitals in order to find out how are these things actually working on the ground. And then you can improve the systems, improve the strategies, and make sure that it's actually reaching those it is meant to reach. So that's the kind of work that we're doing, and we're focusing mainly on Mumbai, but we're also looking at different states across India, because the conditions in different states are quite different.
Thank you very much, Carlo, for also throwing some light on this particular work that you have been very passionately involved in India. And so I think with that, there are no more questions. So we'd like to thank on behalf of all of us at TIFR for taking your time and talking to us on a very, very important aspect of the current pandemic situation, but also on many other related aspects. So thank you very much once again, and wish you take care and stay safe. And I understand that you are already here in India for a year now, and so take care. Thank you.
Thank you so much. Thank you so much. It was a pleasure.
Yeah.
Thank you. Have a great weekend.
Yeah.
See you.
Thanks, India, once again.